So the goals of imaging in someone with acute back pain are mostly to exclude a low probability serious condition, but also to rule in a treatable condition such as stenosis, herniated disc, spondyloarthropathy, or instability. There are several factors which would lead one to recommend early imaging. These would include concern for fracture, such as a major trauma, or minor trauma in an older or osteoporotic patient. Other factors that would suggest early imaging would be concern for tumor or infection, such as someone with age under 20 or over 50 with back pain, history of cancer, if there are systemic or constitutional symptoms such as fever, if there are certain risk factors for infection such as immunocompromise or HIV, or if the symptoms are worse at night or in the supine position. Definitely if a patient manifests with acute or progressive neurodeficits, early imaging is indicated. And in the absence of trauma, MRI is often the diagnostic study of choice. In certain patients, such as those with metal or pacemakers, CT or CT myelography might be indicated. So we'll move right on to our case-based review. This is a 78-year-old with ground level fall, hand weakness, and burning paresthesias. And that box actually says MPGR, in case you can't see that. So I want you to look at this case and think about what is going on. So what is the diagnosis here? Spinal cord hematoma, central cord syndrome, spondylolysis, no acute finding, Brown-Séquard syndrome, or cord infarction. So most of you said central cord syndrome, and that's absolutely correct. So this is usually occurs in the setting of trauma, minor trauma even, fall from standing, in a patient with underlying cervical stenosis. Manifests with upper extremity weakness. Bladder dysfunction is variable, and there's variable sensory loss. But one of the classic findings people complain of is painful dysesthesias, particularly of the hands and also of the feet, as well as anesthesia. So on imaging with central cord syndrome, you see the canal stenosis, but then there'll be increased T2 stir signal within the cord. The cord will be expanded, although in this particular case that's difficult to see because there's this stenosis underlying. There's no signal loss on T2 star or gradient imaging, which is what I'm showing you here on the MPGR. This is the level above, showing you the normal gray spinal cord on MPGR. This is the level of the stenosis, and although there is increased T2 signal, there's no signal dropout to suggest that there are blood products. Okay, our next case is a 47-year-old, acute right greater than left leg pain and urinary incontinence. So I want you to just take a look at this sagittal and axial T2 image. And what is the diagnosis? Ependymoma, epidural hematoma, spondylosis, no acute finding, Cauda-Equina syndrome, or schwannoma. And we'll see. And most people think that this is Cauda-Equina syndrome, and I agree with you. So what you see here is there's a large anterior epidural mass here. Here's the level above, showing you the nice nerve roots swimming in the thecal sac. When we get to the level of, there's this really iso-intense to the desiccated disc with compression on the thecal sac. This little lunar-shaped structure is the thecal sac. All the nerve roots are compressed. So in this case, there's a large extruded disc fragment causing severe thecal compression. And this is Cauda-Equina syndrome. Now, the classic clinical syndrome is saddle anesthesia, urinary retention, and severe or progressive deficit in the lower extremities. All of you that have worked in the ER know that this is a very common indication to get MRI in the ER. It's actually fairly rare, but it's important because it's a neurosurgical emergency. Early decompression of the thecal sac in these cases will result in better outcome, particularly of the bowel and bladder dysfunction. And that's very important in these patients who are often, young patients in their 40s and 50s, and this could be a lifelong problem of bowel and bladder dysfunction. Neurosurgical literature shows that surgery within 48 hours is the best outcome, but in fact within 24 hours is even better. So it is truly an emergency. MRI is also useful in the evaluation of traumatic spinal cord injury. Now, CT is the best for imaging bone, and I'm not going to focus on patterns of bone imaging today. MRI is a useful adjunct to look for soft tissue injury. And on MRI, in the setting of acute trauma, you want to look for cord injury, epidural hematoma, or injury to the ligaments. Acute spinal cord injury can manifest with a range of abnormalities, starting with spinal cord edema. Next on the list is hemorrhage, and then even spinal cord disruption. And the presence of blood is a bad prognostic sign for functional recovery in a patient with a deficit related to their spinal cord injury. So this sagittal stir image shows an area of spinal cord expansion with some central high stir signal. And you can see that there is extensive fluid and signal abnormality in the prevertebral soft tissues, as well as in the posterior paraspinous muscles. What I want to focus on here is that cord edema, or the first stage of contusion, manifests as low signal on T1, which I'm not showing you, but high signal on T2. The next phase in the progression is cord hemorrhage. Now, this is a sagittal T1, again showing some cord expansion here. You see CSF signal on either side of the cord above and below the level, but there is focal expansion in the cord. There's increased stir signal extending within the cord, but there's central low T2 or stir signal, and those are the actual blood products. And note again, there's some prevertebral fluid and hemorrhage, and that this disc appears injured. There's some soft tissue injury in the posterior paraspinous muscles. Cord transection is, again, it's fairly rare to see, but when you see it, it's a quite striking finding. Again, you'll see the area of cord expansion, the stir signal abnormality extending above and below, and then at this area of the cord disruption, there's the blood products surrounding it, and then actual fluid signal within the cord. So obviously this has a very poor prognosis for functional recovery. So here's another case for you. 89-year-old fell while cleaning gutters. This is just a non-contrast CT. I want you to think about if this is normal or abnormal and where the abnormality might be located. So what's the diagnosis here? Spondylosis, otherwise normal, fracture, ligamentous or disc injury, epidural hematoma, or I don't know, better get an MRI in this guy. So most of you thought that there was a ligamentous or disc injury, and you're absolutely correct. So here's the MRI on that same patient, and what you're seeing is that on this sagittal T2 image, this is an older person, so there's disc desiccation, the discs are dark, but this one level, the disc is bright, and the disc space is widened. There's a lot of prevertebral soft tissue swelling. This is actually a disc injury. So now when we look back at that CT scan, you can see that the disc heights here are fairly preserved. This disc shows the classic signs of disc degeneration with end plate osteophyte formation, irregularity of the end plates, the disc space loss of height. Now this level is a little unusual, right? Because the disc space on first glance appears spared, but in actuality there's a fair bit of disc degenerative changes at the end point. So the key here is that the disc space is too wide for the level of degenerative change. And then we also discussed the findings on MRI of increased T2 stir signal within the disc. The cord signal in this case is normal, which is good for him, but he probably is going to need a fusion because this is an potentially unstable injury. Here's another case. This is a 59-year-old man. He was struck by a car. You can see that there is an abnormality here. But what do we do next? One, this is a stable fracture, recommend bracing. 2, alert orthospine of the unstable fracture and move on to the next case. You're in a busy ER. 3, recommend myelography to rule out a dural tear. Or 4, recommend MRI to evaluate for epidural hematoma. And most of you were absolutely correct. You're going to recommend an MRI. So this is the MRI in this case. These are selected axial sequences, and this is T1. You can see that there's this bright material on the T1, mostly posterior, but surrounding the thecal sac. bright on T2. And this is an MPGR sequence again, and you see this kind of etching appearance around this material. So this is actually an epidural hematoma. Epidural hematoma, it's particularly important to think about this in someone with either ankylosing spondylitis or DISH, because these spines act as one unit. You tend to see an extension fracture, and this fracture pattern is associated with increased incidence of epidurals. If we go back to the CT, and I'm not sure that I expect you to see this projected on the screen, but there is too dense material within the central canal. So as we look up higher, there's this rim of low density, but then we lose it right here. There's too much dense material. And that might be something that you would see if you carefully examine this case on the PACS. The MRI, here's the sagittal view. And again, you can see in this case, by the time we got the MRI, there was a fairly extensive epidural hematoma at this point. The arrow is just pointing to the extension fracture. The recognition of epidural hematoma is very important because this can cause thecal compression, and decompression may help improve the functional deficits. Okay, so now we're going to move on to infection and inflammatory conditions. So this is a 40-year-old with C3 HIV who's getting treated with therapy. He developed back pain, and he actually underwent the nuclear medicine study first, followed by the CT scan. And that actually sparked an MRI. So in this case, the MRI shows decreased T1 and T2 signal within the vertebral bodies compared to these surrounding normal levels. There's end plate irregularity, and then on T2, this is a normal appearing disc in a young person. There's nice water signal in the disc. There's a little bit of signal loss here, which may just reflect desiccation. But this disc is very different from the other levels, where there's a lot of disc space loss of height. And for this amount of disc space loss of height, there's too much T2 signal in this disc. You would expect to see a desiccated disc. STIR shows similar findings. And when we give contrast, you can see that the disc is enhancing compared to the other normal appearing discs, as well as the bone. Now in this case, we want to look for complications. So we'll look on the axial sequence. Here's the T2. You can see the thecal sac here with the nerve roots having plenty of space. There's a little bit of enhancing epidural venous structures here, epidural veins, but there's not actual enhancing tissue. So this case is just discitis and osteomyelitis. There are not the complicating factor of an epidural abscess, but there is prevertebral abscess in this case. And as a comparison, we'll look at this 30-year-old schizophrenic IV drug user with back pain. He came in with this CT scan. And on this image, you can see that he has some progressive findings. So in the lower thoracic spine, the bone is abnormal here. There's a mixture of lytic and sclerotic features to the bone. It's involving the adjacent bones. You can see on the axial soft tissue window that there's a lot of prevertebral soft tissue abnormality. He went on to get an MRI also. And on the sagittal T2, again, there's increased T2 signal within the vertebral body as well as within the discs. And with contrast, there's a lot of enhancing material both within the residual vertebral body, in the discs, extending across the disc space into the level above. And on the axial sequence, we're going to look for the complications. We see the prevertebral, perivertebral enhancement, but we also see this theater curtain type of appearance where there's abnormal material in the intrathecal, the epidural space, which is, epidural not intrathecal, which is pressing on the thecal sac, and it's enhancing. So in this case, we have discitis osteomyelitis, which is complicated with epidural abscess. And as this progresses, you can see pathologic fracture as in this case. Okay, here's the next case. This is a 24-year-old with gluteal abscess, headache, and back pain. I want you to take a look at these images and see what you think might be going on. So what is the least characteristic finding of this diagnosis? Large paraspinous abscess, bone destruction with gibbous deformity, involvement of intervening discs, or involvement of non-contiguous levels. And most of you thought involvement of intervening discs was least characteristic. Some thought involvement of non-contiguous levels. So this is tuberculous spondylitis, also known as Pott's disease. And the thoracic spine is the most common site for tuberculous spondylitis, where you see a large paraspinous abscess. And most of you got this question correct in that the discs are often spared. You can actually see skip lesions with tuberculous meningitis or tuberculous spondylitis, where there will be levels involved separated by non-involved levels. Brucellosis can appear similarly, but usually occurs in the lumbar spine. Okay, here's our next case. This is a 59-year-old woman who presented with back pain after a flu-like illness. And here is our axial T1 and T2. And I want you to focus on this facet joint, which is ill-defined on the axial T1. We see there is some atrophy in the paraspinous muscles, and we see fat here. On this side, there's a little bit of distortion of these normal planes. And on T2, the vertebral body or the facet is a little bit bright, and there's a joint effusion. When we give contrast, we can see that there's a lot of enhancement within the joint, in the bones surrounding the joint, and in the paraspinous muscles. So this is actually a septic facet. And this is a pyogenic facet injection. In this case, the CT was normal, but in some cases you can see the same findings as with septic joint elsewhere with bone destruction, decreased T2, joint effusion, and enhancement. Okay, so 35-year-old with ascending sensory level and lower extremity weakness. I want you to think about what might be going on here. I will direct your attention to the T2, where there's signal abnormality within the cord, which is somewhat expanded. It extends over multiple levels. On the pre-contrast image, there's a little bit of low signal, and there's enhancement, discontinuous nodular enhancement on the post-contrast. Here on the axial, again, showing the signal abnormality within the cord and the enhancement. Causes for this abnormality could include all the following except, okay? Lupus, viral infection, rheumatoid arthritis, idiopathic, or syphilis. This is kind of a hard one. Voting is open. So most of you thought rheumatoid arthritis. You're absolutely right. What I'm showing you on imaging is transverse myelitis. So that's defined by a cord lesion, usually greater than 2 vertebral segments long. Classically will involve more than 2/3 of the axial dimension of the spinal cord. There can be cord expansion. Enhancement is variable, and I think I've certainly seen many cases without the cord enhancement. Commonly, you'll see this in the thoracic spine. There are a lot of causes of transverse myelitis, idiopathic or secondary. Some people use the term transverse myelopathy to describe secondary transverse myelitis, reserving transverse myelitis for idiopathic cases. But secondary causes include autoimmune disease, lupus, Sjogren's, sarcoid, mixed connective tissue disease, viral infections, which I've listed here, and then other infections. You can also see it as part of a post-vaccination immune response after radiation, but of course you'll have the clinical history in that case. And then with a paraneoplastic syndrome, you can also see transverse myelitis. The differential is going to include multiple sclerosis, but this should have a much more indolent clinical course as opposed to transverse myelitis. A neoplasm, which will tend to be more irregular, may have cystic or hemorrhagic components, and again may have slow symptom onset, and then cord infarct. Okay, so here's our next case. This is a 30-year-old who presented with flaccid paralysis. On the stir sequence, you can see that we don't see the nerve roots of the cauda equina very well. On T1 pre, the nerve roots are in this vicinity, and then on the post-contrast sequence, they're enhancing. And on the axial image, again, you can see how there is enhancement of the nerve roots. What's the most likely diagnosis? CIDP, AIDP, medulloblastoma drop mets, vitamin B12 deficiency. The eponym, but I did not fool you with my soup of initials, this is actually AIDP, which is the same as Guillain-Barré. So AIDP stands for acute inflammatory demyelinating polyradiculopathy. It's distal paresthesias with ascending paralysis in a young person. Cranial nerve involvement is very common. What might distinguish this from a neoplastic cause is that there are smooth enhancement of the cauda equina and nerve roots. The roots may be thickened, but they're not nodular. So now we are going to move on to masses. This is a 70-year-old fellow with back pain. I want you to look for the etiology of the back pain. And you can see that there is a compression deformity of L1. But I just put this case in here to remind you to always go through your normal checklist, which includes looking at the pedicles on the frontal view. And clearly there are some abnormalities in the pedicles. Oh, by the way, she has non-small cell lung cancer. And when you look at this, you can see that indeed there are multiple sclerotic bone mets that involve the pedicles. So the back pain may have come from that L1 compression fracture, or it may come from all these multiple sclerotic bone mets. Okay, 61-year-old, 10-day history of back pain. So I want to direct your attention to the T1 pre. We see low signal within this vertebral body and probably also in this vertebral body. It's bright on STIR or T2, and it enhances. There's posterior bowing of this posterior cortex, and if we look on our axial image again, we see this sort of theater curtain configuration of enhancing material, telling us there's epidural extension. So this case was metastatic renal cell carcinoma. The classic findings in metastatic lesions to the vertebral body include posterior vertebral body involvement and pedicle involvement, sparing of the disc, that draped curtain appearance to indicate epidural extension, and you always want to look very carefully for that. And common mets to the spine would include prostate, lung, breast, but multiple things can metastasize to the spine. There are certain findings that would lead you to a diagnosis of metastasis rather than a benign pathologic fracture, an insufficiency fracture, and that would include complete marrow replacement, convex bulge of that posterior border of the vertebral body, pedicle involvement, epidural mass. With an osteoporotic or an insufficiency fracture, you could see a band-like signal of low T1 signal, which would be due to the crushing of the the bony trabecula. You don't necessarily see that with metastasis. Okay, next case, 35-year-old with back pain. I'm showing you a T1 and a T1 fat sap post-contrast sequence. And clearly there's an enhancing mass lesion at the conus medullaris that's a little bit iso or low on T1 and has heterogeneous enhancement. Think about what you think the diagnosis is here. And this is a classic appearance of myxopapillary ependymoma. So intensely enhancing ovoid mass at the conus, phylum, or cauda equina. It can completely fill the canal, and classic is iso-intense to the cord. In this case, it's hypo-intense. Here's another case. 35-year-old comes in with progressive myelopathy. This is post-contrast images. So you can see on the sagittal there is a intradural extramedullary mass lesion. Here's the spinal cord, which is compressed. It's uniformly enhancing. Maybe there's a little bit of a dural tail there. And this is actually a meningioma. So meningioma is the classic intradural extramedullary lesion. 90% of meningiomas in the spine are going to occur in this location. You can also see them in the extradural space. They're responsible for 25% of spinal canal tumors. Most of them are going to be thoracic. And although calcification is common on pathology, it's less common to see that on imaging. So here's another case, a 35-year-old who presents with a radiculopathy. And I'm showing you T2, T1 post-contrast, and then sagittal T1 pre-contrast, and showing widening of a neuroforamen, which is filled with this homogeneously enhancing lesion, which has T2 signal hyperintensity. And this is a schwannoma. Schwannomas, of course, may be cystic or hemorrhagic. They usually are intensely enhancing and classically form a dumbbell shape as they exit the foramen. Most common to see these in the thoracic spine. Again, another classic intradural extramedullary lesion, 70% are in this compartment, but they can also be extradural, combined, or rarely intramedullary. They're responsible for about 30% of the intradural extramedullary lesions. They're slightly more common than neurofibromas, and schwannomas tend to be eccentric to the parent nerve with a well-defined capsule, although I would say that's hard to evaluate on MR. And just as a comparison, I'm showing you plexiform neurofibromatosis, where again, in this case, you're seeing multiple nodular thickened nerve roots as they exit. So finally, we're going to talk about vascular lesions. This is a 70-year-old man who's critically ill, has acute weakness and sensory loss, showing you a sagittal stir and an axial T2. And this is a cord infarct. So on our stir sequence, we can see that there's increased signal within the conus medullaris. It's really localized to the central gray matter. The conus is slightly expanded. That may enhance, this case did not. And MRA is generally not helpful in this case because usually this is due to a problem with the anterior spinal artery, and it's just too small to see on MRA. Causes are several. Atherosclerosis, we commonly see them after thoracoabdominal aneurysm or aortic surgery. Systemic hypotension can contribute dissection or, in some cases, coagulopathy. 29-year-old with lower extremity weakness and progressed to inability to walk. The pre-contrast T1 shows a little bit of irregularity in the cord. There's signal dropout on T2. Stir is heterogeneous. And on post-contrast T1, again, we see this little irregularity of cord signal, but on close inspection, there's not really enhancement. So this is cord hemorrhage, and it's just like with cord hemorrhage in the cervical spine after trauma, low T2 signal, T1 signal can be heterogeneous. There's cord edema extending above and below the level of the hemorrhage, manifested as increased T2 signal. In this case, there was no enhancing lesion, and the spinal angiogram was performed, which was negative. There is a differential for cord hemorrhage, which includes a dural AV fistula or AVM, cavernous malformation, hemorrhagic mass lesion, or no underlying cause, as in this case. This was spontaneous. And we were only really able to make that diagnosis of spontaneous cord hemorrhage after appropriate follow-up and re-imaging and not finding an underlying lesion. So here's another case. This is a 60-year-old man with progressive sensory loss from the toes up, stair-step, waxing and waning pattern, sensory loss and weakness. And on T2, you can see that the cord signal is not normal. There's some increased cord signal. There are all these areas, these sort of serpiginous areas in the CSF space, which enhance with contrast. This is a MRA showing these enlarged serpiginous structures here. And again, axial, dark areas, tubular areas of low T2 signal. Stir again is showing you the cord signal abnormality. This is a different patient but the same diagnosis. This is a spinal angiogram. And what you can see is that there's filling of this abnormal serpiginous vascular structures. And indeed, this is a spinal dural AVF. So enlarged edematous cord, prominent flow voids, the vessels enhance. And really, spinal angiogram is the gold standard for diagnosis, but it's also a treatment modality. Okay, 69-year-old progressive right lower extremity weakness, numbness, and urinary retention. And again, I'm showing you some increased T1 signal with this heterogeneous signal on T2, some increased T2, some decreased T2, and maybe a little bit of enhancement here. The brain MRI was obtained in this patient, and we see these two additional lesions in the tectum and in the frontal lobe. So what's the diagnosis here? Metastasis, cord AVM, cavernous malformation, or neurocysticercosis. What'd you guys think? You thought cavernous malformation, and you're absolutely correct. And what helped us in that case was that there were additional brain lesions.